Oh, hey, Chris.
Chuck, how are you?
I'm fantastic. How are you?
And well, it's a nice Sunday here in St. Louis. Have had a nice full day so far. Had a little washout in the morning with our fantastic fellow Elizabeth Wall, who oddly enough, she did mention how you mentioned your fellow by name, and I have not yet mentioned my fellow by name.
Damn.
Currently rotating. So Elspeth got a shout out last time. Harris has gotten a shout out before. And of course, last but not least, Dr. Elizabeth Wall. Welcome to our fellowship.
Well done. Yeah, podcast jealousy. Who knew? Who knew there was such a thing?
Oh, but it's
Um,
good. It's a good day in the house. I've got this wonderful pork shoulder roasting in the oven. I'm very excited to bite into that later. And yeah, it's kind of how I build my Sundays now is around food. So
that is one thing that'll never come out of my mouth. I've got a wonderful pork shoulder roasting in the oven. Won't happen. So,
well, you were kind enough to come by the house yesterday. So, you saw our kitchen and everything, and you did mention that you were always pushing for, a bigger range.
it's funny because Chris now lives within walking distance to me. It's not the shortest of walks, but it's also not the longest. I don't know how much, maybe half mile or something. And so Tully and I walked over, and my wife was completely humiliated by me once again. I had a bunch of stuff I had to bring over to Chris and a housewarming gift, and so I had a backpack and all this stuff, and I was carrying this plant. She wanted to get off the main roads as quickly as possible. But we love your new home. Congratulations, and I know you're gonna have many happy years in it.
Thank you. I'm currently sitting in the basement in the gym because it is the closest to the internet router. So I am doing my absolute best to improve the quality on my end.
It is working. So two things generally about the pod. The first is, and you throw this out there on Twitter. We have some new swag out there.
Yes, absolutely. We mentioned it at the end of last week's episode. But for those of you that are wondering what the swag is, it's essentially some croquis that you could use for your loops or your glasses or your sunglasses to hang them around your neck. And I remember always trying to find the right pair of croquis for my loops when I was starting out. And I finally switched them. I did my first case today with the new upper hand croquis. And if you catch me at the ASSH meeting in San Francisco or at the ASHT meeting here in St. Louis, I will have a bunch of them in my bag, and I am looking forward to giving them away.
I love it. Chris is going to be like the most popular person at the meetings, handing out swag because there's not that much swag to be gotten anymore at these
There's,
meetings.
I'm just going to start throwing it from the podium. It's going to be awesome. But speaking of the ASSH meeting, I just had a very brief text conversation with our sometime guest, longtime listener, and of course, friend Sam Mogdateri over in Washington, D.C. And he told me that he listened to the episode and he is on the fence now about coming to the meeting in person. He still obviously has to, make some logistical arrangements. And for a lot of us, the COVID concerns linger. But he's now thinking about it based on the stellar job that Amy and John did last week of telling us how great the meeting's going to be.
Hey, if one person who wasn't going to be there comes, then I will consider that podcast a success.
And one more thing, he did mention before the episode even ended, he ordered a Maui Jim sunglass case to put his 2.5 loops in based on some sage wisdom that he received.
That is awesome. The other thing we're working on the podcast is maybe a little premature, but hey, it's coming. Chris and I have gotten questions about some type of more, more formal or more structured communication. So we're thinking about an email newsletter, which would be infrequent, maybe once a month. We're going to try it with just important information, whether it be Chris and I's favorite journal articles, what's happening in the world of hand surgery, opinions for sure, because we're full of them. But if you look at if you look in the show notes for episodes going forward, there'll be a link to sign up for the newsletter. Or if you just want to reach out to us on any of our platforms and share your email address, we will include you. And we'd love if you joined us.
Send us a note, handpodcast@gmail.com. We would love to hear from you. Get on the list and then also send in questions. Remember, Chuck will literally answer anything that you ask him on air. And I will surprise him with it because I check the email address more than he does.
Yeah, way more than I do. That is true. I have a case. Can I share a case?
Sure.
All right, this is one, I have this thing where I really try to be good about taking pictures. And when I don't do it, and it was something that should have been photographed, it literally kills me. It drives me crazy. I perseverate the whole case and for several days later. But we had a super interesting case that I did with Dr. Elspeth Hill, the hand fellow. And it was a gunshot wound. Where the entry was near the pisiform, and the exit was dorsally through the thumb metacarpal. And it was pretty impressive. And the exit wound was large, the metacarpal was destroyed, the trapezium was injured, and the exam preoperatively was not very helpful. And so we elected to proceed to the operating room to do an acute carpal tunnel release because of concerns of numbness, and to explore both the distal ulnar tunnel and the median nerve. So we get to the OR, we open things up, and the ulnar artery was clotted, but there was good blood flow to the fingers, so we weren't overly concerned by that. The ulnar nerve was intact, and the median nerve was 90%, lacerated is the wrong word, but 90% not in continuity. And then we dealt with the metacarpal. My question to you, Dr. D, as a nerve expert, is what do you do now? We have a patient who is a victim of violence, who, I don't like to make assumptions about who will or who will not come back to the office, but I'm not sure if this person could be counted on for long-term follow-up. What do you do in the OR that day before I tell you what we did?
So you said the ulnar nerve is structurally intact. You don't know about a concussive type injury, as we mentioned on a prior episode, the different kinds of injuries you can have to a nerve. So I would not do anything else for the ulnar nerve other than a comprehensive release of the distal ulnar tunnel, the hypothenar fascia for zone 2. And it's interesting what you could do for the median nerve at that level. So I'm assuming your 90% transection of the nerve is at the level of the carpal tunnel.
It is in the middle of the carpal tunnel, and there is, evidence visually, both by loop and a microscope, of a visual zone of injury on either side of the discontinuity.
And you're there within 24, 48, 72 hours of the injury?
For sure, probably 18 hours of the injury. It ended up, the next morning we got time and took him to the OR.
So I think old school, you close and you call it a day and you have them come back to the office, 2 weeks later and plan for going to the OR after the zone of injury on the nerve has theoretically declared itself within probably 3 or 4 weeks. And then you proceed with nerve grafting. I think that it would be acceptable to me if you had consented the patient for an autograft, which you may or may not have, to proceed with an autograft. And what I would probably do is try to isolate, if I could, where the recurrent motor branch had come off of the median nerve. Now, it sounds like that'd be really hard just because of the location in which your transection is. It's probably right where, most recurrent motor branches are coming off. But you could tease apart the recurrent motor branch if you can still see it going to the thenars, and then graft preferentially into that, really funnel things into there. After going back, being a little more aggressive on your zone of injury, or your resection proximally. I don't know if that all makes sense. And then after that, I think that you could, if you visually saw an area of transition, resect back a little more and go for the complete grafting at time 0. Now that's wading into controversy, and I think there are a lot of people who would say, "No way, why would you do that?"
So I'm going to flip it around. Now that I've exposed myself, and say, well, why? So we did not have consent for an autograft. We talked about an allograft, but decided that an allograft was not appropriate in this situation. And so why would you not? What do you have to lose? What does the patient have to lose by a resection of a presumed zone of injury and repair, if it's able to be primarily repaired?
No, I like it. I guess I hadn't mentioned that or thought about that because I had assumed that the zone of injury was relatively wide and you wouldn't be able to get it together primarily without tension. But I've actually done that with ulnar nerves at the same level. And there's some case series out there about ulnar nerve injuries from distal both bone forearm fractures, with the ulnar nerve being injured in the distal forearm, kind of just proximal to the wrist crease. And I have primarily repaired those because of that very reliable topographical relationship of the motor and sensory components. I repaired them primarily, and I will admit, I have flexed the wrist in order to get that to, to come together, but then I will check it with the wrist in neutral to make sure it's not gapping and I'm comfortable with it. It's a very fine line, and I think you'll find many old school surgeons who would shake their heads at that. But then the key there is then making sure that you keep the wrist flexed in the dorsal blocking splint of sorts, and then gradually, progressively bring the wrist out into a more neutral and then eventually slightly extended posture. And the way I've done that in the past is to monitor it with ultrasound. So obviously it takes the right patient, because the ability to come in for those kinds of serial monitoring exams can be a little challenging.
I love everything you said. I have a comment and a question. My comment is, it's nice. Well, let me just back up for historical reasons. It used to be that in orthopedics, we would treat patients with a wrist flexed posture for certain fractures. I think it's the so-called cotton loader position, distal radius fractures, which is a really effective technique to obtain a distal radius reduction, but it doesn't work out well in the end because of the increased pressures inside the carpal tunnel with extreme wrist flexion or extension. So we don't do that anymore. But in this case, we've released the carpal tunnel. So we're not so worried about the pressures. And so we were quite comfortable with flexing the wrist to minimize the tension. My question is there any role for a slightly larger suture to detension the repair, a 5-0 or something like that, epineurial stitch crossing over to detension a bit on the repair site? Is that something you have done or would advocate for or against?
I haven't done, I wouldn't advocate for it. I know that there have been some groups that have tried to study it, including our own Dr. David Brogan, using not that exact technique, but looking at ways to splint a repair. And the experiments never quite got off the ground. At the end of the day, if you don't have tension on your repair, then you should be in good shape. It kind of depends on the caliber of suture that you were to use. So an 8-0 nylon suture, which, classically in the literature, we talk about the 8-0 nylon test. There's a really nice paper, I think it was from Jeff Greenberg's group, that looked at the characteristics of 8-0 nylon versus 9-0 nylon versus the relative normal strain in a nerve. 8-0 nylon, you can get away with having a little more tension than the native tension in a nerve occasionally, whereas a 9-0 nylon will not let you do that. So for me, if it comes together with a 9-0 nylon, I feel comfortable knowing that it's not going to be under excessive tension, provided that the wrist doesn't get fully extended violently. 8-0 nylon, I still kind of wonder. So I guess the question about, what caliber suture to use for your coaptation is probably different than what you're describing about using a detensioning stitch. I don't have any experience with that. And actually Elspeth, I think, has asked me about that before when we were having one of our sessions. And I told her I was not an advocate for it.
Yeah, she may try to bend your ear a little bit on that technique. So bottom line is relatively small caliber bullet, relatively narrow area of discontinuity with visual injury, not that huge. So we excise what we consider the injured segment and then a little bit more. And we were able to primarily reapproximate without a detensioning suture, but we added a detensioning suture and we flexed the wrist. And my opinion here is we didn't lose anything. If he does not get recovery, we can come back and graft. If he gets recovery, we're all going to be happy we approached it this way.
So you removed the 10% that was intact, right? Structurally intact.
We did, and it was a very posterior and ulnar 10%, which didn't worry me much.
Now, how do you know, how do you judge taking a little bit more than the visually injured segment? Like what's the...
Yeah, well, this is a classic paper that's not been written yet, Dr. D. We use 2 millimeters more than the injured visible segment on each side.
That's said with such confidence. Wonderful. I can't wait to read that paper when it's finally written. And then we'll call it a classic. There's Chuck Goldfarb again, a workman just hammering nails.
That's right. In my chosen field of nerve.
Hey, did you voluntarily present a nerve case? That's amazing.
I knew you'd be excited about it. That's one other reason I was frustrated. I didn't have a picture.
Love it. I love it. Well, why don't we jump into this week's topic, apropos to our theme last week of the ASSH annual meeting. I actually got a couple of emails from the HBR, the Harvard Business Review listserv that talked about how to give a great presentation. And there were two, I think, really good articles in that set. One was from January 6th, 2020 by Carmine Gallo called What It Takes to Give a Great Presentation. And the other one is actually a little bit older. It's from How to Give a Killer Presentation by Chris Anderson, which is from June 2013. And I like the Gallo one a little bit more just because it breaks it down very easily about how to give a great talk. And it was top of the mind for me because I feel like we're getting closer to normal, although we're all still really hesitant about Delta. I'm going to be giving a couple of talks at the ORS-ORAF Clinician Scientist Development Program this week. Then I've got the Hand Society a couple weeks later, as do you, with some presentations. And then we have the ASHT meeting the week after that. So I'm in talk mode. And then I also just gave grand rounds for our department a few weeks back. So all this has been top of the mind for me in terms of thinking about how to sharpen my presentation skills.
You know, it's something that I always am interested in reading about. One of the things I struggle with are these type of discussions are tough because they're really not discussions about medical presentations. And so there's certainly takeaway messages that are important, but it's not as if you can give a talk like they describe or perhaps like Steve Jobs used to give, because we have to do things somewhat differently, but we absolutely can learn from these type of discussions. And I will say that Chris Anderson, I think, is one of my favorite thinkers. You know, Chris was I'm on a first name basis with him apparently, was the prior editor of Wired magazine, which I know you know is one of my favorites. And he wrote the concept of the long tail, which I think we've talked about in this forum. If we haven't, we will one day. And I think he really did a great job in this article as well.
Well, let's jump into one of the articles. And the first tip that they give is great presenters use fewer slides and fewer words. Now, we talked about this a little bit when we gave, we had a podcast episode about virtual talks, but say you're just talks in general. I mean, how do you construct your slides? Because I remember towards the end of his teaching career, Dr. Gelberman giving talks and just being mesmerized by the quality of the pictures he would have in his talks. Now, granted, the department had a photographer at that point, which enabled it, but I thought those were incredibly powerful slides.
Yeah, I think we should be clear. You know, if you were giving a scientific presentation, a 5-minute podium talk about your research, that's different. If you're giving a bigger picture discussion on nerve or congenital or sports or whatever, I think you can do a little more. You can work with these techniques a little more. And there is no doubt that Dr. Gelman, as his career advanced, used fewer words, fewer bullet points, nice visuals, and more talking. But let's be honest, that requires a lot more preparation. You know, none of us, I would hope, would go up there and read the bullet points because we know that's just not that helpful. But some talks require bullet points. And I just recorded a presentation for the Hand Society, and I didn't want to use bullet points, but I found that it doesn't convey the message when you're kind of working through research without them. And so I love this concept. Fewer words, more pictures, more verbal, I guess, depth to each slide.
You know, I think that your point is right on about, you know, a 2 to 5 minute scientific paper presentation has to be very tightly scripted. Not that you're reading off of the slides, but it has to be tightly scripted. It has to be formatted in a certain way. It can't be the beautiful, here's a picture of a nerve kind of talk. And I actually just met with a former student that I've been working with, who is now a resident at SLU, Alexa Powers, and she's giving a talk at the Resident Fellows meeting in a couple of weeks right before the Hand Society. They've got 2 minutes. So I told her, I was like, look, like you got to be tightly scripted, got to practice it a bunch so it doesn't sound like you're reading. But there's really no room for error because you don't want to be that speaker that runs over and throws off the whole program. Yeah, I've noticed that the talks that I give every year in terms of the, you know, introduction or overview of plexus or nerve studies, as I go back every year, I take more words out. And that's also me becoming more comfortable with my ability to remember the things to hit on those slides. Now, I'll admit in kind of the speaker notes section, I will just remove the text that was on the slide and drop it in there. So I remember if I have presenter mode available, what points to hit. But I think that the point in this, that they make in here is that, people remember pictures more. They remember less about the words that you're saying and more about stories that you're telling and the points that you make when a picture is on the screen. And the second point is, great presenters don't use bullet points. I agree with you. I think that in our field, in our world, unless you have a picture on the screen, you have to use some bullet points, some kind of text.
Yep, exactly. But I should look. I would never consider myself a great orator. Hopefully, I get my message across. It's something I think I've gotten better at, and hopefully, will continue to get better at. I hope content really matters to the audience, but you want to make it easy on the eyes and easy on the ears, and just it's really an acquired skill, which gets to the third point of this Gallo article, which is that great presenters enhance their vocal delivery. And so, regardless of the political spectrum, I think most would agree that Obama is a great orator. And I'm never going to present like he presents, but practice helps. Having even a non-medically involved person listen to your talks helps. It is a skill set, though.
Yeah, and this kind of gets into the stuff that's in the Chris Anderson article, but I mean, it's connecting. And so your intonations and the way that you talk are going to vary if you can connect with people in the audience. So one of the suggestions in his article was to find 5 or 6 people in the audience and constantly make eye contact so that, you can connect with somebody and see that they're following along. And it helps you understand when people are engaged and not engaged.
Absolutely. Well said. Do you consciously think about how the tone of your voice, the cadence of your delivery, the volume of delivery? I mean, clearly for some people, that just comes naturally. If it doesn't, do you think about those things?
I don't know if it came naturally to me. I think I worry less about it. I became more comfortable speaking in public for whatever reason. I think there were things that I did growing up in terms of activities that helped. I wasn't like a debate or anything like that, but I did do a lot of like performing arts, which I think helped my ability to feel comfortable speaking in public. By no means am I an expert, and I'm not the orator of the year, but I do feel comfortable with that. And I'll be honest with you, the podcast has helped a lot in terms of just being able to think on the fly and to talk and to work through things and to remain confident and conversational about things. So we were talking before about benefits of the podcast. That's probably one that I hadn't thought about a lot before. But I do feel more comfortable in a lot of venues because of just we put ourselves out there every week.
It is really true that I think my next live symposium where there's multiple different people giving their opinions, I will be so much more comfortable than I would have been pre-podcast. So what Chris and I are saying is we hope some of you out there start your own podcast and jump into the game. We're not afraid of competition. The more the merrier. We're kind of like Elon Musk. If you want to build an electric car, go right ahead. But I don't know if you're going to overtake the Tesla here.
Are you bragging right now, Chuck?
Definitely not. We want you out there. We want more people in this space.
So one of the last points in the Gallo article is about rehearsing. And I admit, I do not rehearse as much as I should. But for example, the grand rounds I was asked to give for our department, I practiced that one because that talk meant a lot more to me than many other of the presentations that, I've given recently. So I do think that rehearsing helps. We don't always put in the time. I tend to kind of take my rehearsing time and really just refine my slides and think to myself what I'm going to say. But sometimes it is super important to time yourself and just to get the words out, to know the right things to say at the right moments.
Well, I think it is a really important point, and Gallo cites Martin Luther King Jr., who comes across as one of those spontaneous speakers that could say anything and make it sound beautiful. But there was much practice that was behind the I Have a Dream speech, etc. I'll tell you my personal story. of when I learned to practice to focus my delivery. And if there's any of our current residents listening, hopefully a touch of this will resonate. But when I was a fourth year and a fifth year resident, I was fortunate enough to do the hand rotation by a fluke of need in the department. I volunteered to do it twice. And that was back in the day. There was a little more heat and a little more expectation for our anatomy sessions. And it was a 100% from memory and had better be word perfect. And I spent hours preparing each of those. And they were every week we had an anatomy session. And I practiced and practiced in the shower in front of my wife. I mean, not in the shower and in front of my wife, but in the shower or in front of my wife. I was constantly practicing. It was something, and I got better.
Well, I mean, I think that when the stakes are high, we've talked a little bit about my feelings about the fellowship, and I got the much softer end of things than when you were in training. The stakes are high, the expectations are high, and you don't want to get it wrong. And I remember even as a fellow here watching the residents give what I called at that point their recital. You could tell the ones that had put in the time, and honestly, at the end of the day, I'm sure that they learned the material quite well. The next step is then learning why it's important to memorize those things and recite them in a certain way. I should say that along the way in my residency training, one of the expectations was to give a lot of presentations, whether that was something as routine as indications conference, but also giving indications, but then also giving, say, like a 15-minute talk on a random topic. And it was usually the PEDS service that was the most notorious for making you give a talk. And it was painful at the time, but it was super, super helpful because you learned how to synthesize information. You learned how to make slides. And oftentimes, like, for example, on our trauma service, you would have to do kind of the cases, the pre-op, post-ops, but then there was also like a 45-minute lecture that you had to give every month, in which you truly learned the topic well, figured out how you operate as a speaker, which I think, was probably not the intention of the rotation, but it was certainly a nice benefit.
I think what you said is very true. And I think that is really an important lesson for all the trainees that, yes, these are asks in a training program or in a fellowship program, but you will get benefit from each of these efforts in knowledge, in skills. And we had to give, in my fellowship, we had to give a presentation every week. And so we put together a PowerPoint for a presentation every week. And yes, it was torture, but I'm a much better PowerPoint presentation builder, much faster, much more efficient, and can really put things together quickly, which has served me well for many years. And so there is a lot of good to come out of it. You want to switch over to the Anderson article?
Sure. Yeah, I think we've kind of been sprinkling in some of the Anderson stuff along the way. I mean, I think the biggest thing I took away from the Anderson article is something that I've learned along the way in my short career is to tell a story. And it's a good talk will make people think, and you don't necessarily need to have them come to the conclusions and that you have intended, but telling a story will allow you to take them on a journey. If you do it right, it can show them kind of why for example, like I gave the talk on brachial plexus and the work that we've done. And the first portion of that talk was mainly about kind of showing a case, showing something that I thought was an amazing technical outcome, and then showing how the patient really didn't like it. And then using that as a segue into kind of why we're studying what we're studying in our, brachial plexus clinical research lab. And I think that, people were able to follow along with that. I got a couple of notes from a lot of people that I respect, kind of saying how that story worked out really well. And I had not really used the story a whole lot in many presentations. So I don't know how often, you have the opportunity to do that with a longer kind of talk, but it certainly captures people's attention and it engages them a lot more.
Yeah, well, first of all, I don't know if I said to you directly, but your talk was spectacular and you really achieved your goal of telling a story about your research while imparting really important lessons. And so it was really, really well done. I don't know if that's on YouTube, but people would love that. I mean, certainly there's different venues. That's another story. I think it's harder to do over Zoom. It's harder to connect with your audience. But really, if again, not a scientific presentation, not even some of the symposium type presentations, different kind of presentation to tell a story, tell your story. It's just an opportunity. I love what Anderson said about nerves. No matter how good you are at this, it's okay to have nerves, because in some ways it does help you. It's one example of something that helps connect you to your audience.
We talked a little bit about Amy Cuddy in the episode about the ASHT upcoming meeting and the power posing. I think whatever it takes for you to feel confident and to manage your own nerves, you got to do it. And that's different for everybody. But I think part of it is acknowledging the fact that you're going to be nervous and channel that energy into something that'll be productive. And unfortunately, it tends to be a bit of a trial and error kind of situation.
Yeah, absolutely right. I think one of the, this is a little cliche and maybe a little not in our field, but I love the quote, which reads, "A successful talk is a little miracle. People see the world differently afterward," which is really powerful. And again, what you had many goals in the talk that you gave to our department, but part of it certainly was telling your story, but part of it, I hope and assume, was to potentially inspire a trainee to see a problem and how to tackle it from different angles. And so that has just great potential to make medicine better and give the residents a little something. And so while it's a little cliche for our world, it can absolutely be true.
I'm working on getting that talk up to YouTube. I have to find a way to blur out the patient face that's on there, who, he gave us permission to use it locally. But before it goes out there, I want to make sure that we're on the up and up with that. But yeah, that's, I remember seeing presentations from visiting professors before who I got inspired by. And, listen, there are a lot of areas in our field in orthopedics, plastic surgery, hand surgery, neurosurgery, nerve surgery, where there are a lot of questions that can be answered. And all it takes is an interesting question. And I learned a lot from one of my mentors at HSS, Scott Wolf, who was trying to scratch the surface on this question about how to improve outcomes for brachial plexus injury patients. And he was kind enough to let me run with it. And I think some of it is just kind of letting the idea grow into being your own, seeing it as an issue. And I think that if there was a trainee that was able to pick up on that and think of, well, why don't I approach it this way? Maybe that was, a good thing for them, and hopefully it resonated. So.
Yeah, and let's be clear, we recognize that many in the audience are not going to give big, powerful career presentations or anything like that. But I would argue strongly that if you are presenting to the local therapy group, or you are presenting to high school students, which are like, whatever, I'll throw a talk together for some high school students. But you know what? You may change someone's life, and that sounds a little corny. But if you're talking to a bunch of high school students telling about why you've chosen medicine or hand surgery and what you've been able to accomplish, it really is a powerful opportunity. So I love both of these articles, and they were fun to read.
I mean, to bring it to a close, I think that when we're giving presentations on a topic, for example, distal radius fractures, we all love cases. We love cases more than just cases that will illustrate certain points about how to evaluate, patients, radiographs, how to think about treatment strategies, as opposed to just, here is the literature. If you can find a way to tie cases, together so that you can string together the same points, that's a better talk to me. So for a lot of times, residents will be asked to give a talk on, say, volar lunate facet fractures, or when to use a dorsal spanning plate. If you can find cases that are illustrative, that is the orthopedic or medical version of a story.
Yeah, that's right. And I'll tell you, again, we should close, but I'll tell you that when I was a resident, we transitioned from the concept of a resident or fellow presentation, or quote unquote grand rounds, which traditionally had been a bunch of slides, with a bunch of words. It took years for Dr. Government to imprint his preference on us that it be case-based and have 4 or 5 cases on the volar lunate facet or some type of specialized distal radius fracture. And it is so much more impactful. And gosh, it's true. And I like how what you said, that is our surgical world, our medical world of the powerful presentation.
All right, so now everybody's ready to go give a talk or a presentation or a case series. And hopefully we'll see you guys can share your pointers with us and let us know what works for you.
Please do. All right, Chris, this was fun.
See you next week.
All right.